Welcome to AETCM, the Emergency Medicine Channel.
Yes.
64-year-old female patient came to ER with a complaint of generous tiredness since 2 days. Ambassador noticed the patient had decreased response and patient became progressively weak and decreased food intake since 2 days. On initial 10-second assessment, patient was conscious, drowsy and arousable. On primary survey, coming to airway was patent. There is no pooling of secretions or gurgling. Breathing part saturation is 96% room air. Respiratory rate is 18 per minute and bilateral equal entry. Circulation part, BP was 140/70. Heart rate is 90 per minute. CRT less than 2 seconds. At this point, we keep it 2 large IV cannula secured. Coming to disability, GCS is E3, V5, M6. People bilateral equally reacted to light. Exposure part, GRBC is 644 and temperature was normal. Coming to adjuvants to primary survey, take a VBG pH was 7.35, PCO2 is 35, bicarbonate is 18.5. On creatinine VBG it is 1.5, sodium is 113 and potassium is 3.5. According to the GRB is 644, our corrected sodium is 122. And we take...
How will you calculate corrected sodium?
Corrected sodium, according to GRBs, which is more than 100 milli-deciliter, we can calculate by 1.6 milliequivalent sodium up to 400 milligram, and above 400 milligram we can use 2.4 milliequivalent.
Every 100, 2.4, and other one is every 100, 1.6 to be added to.
Every 100 to 400, 1.6, and more than 400, 2.4.
Okay.
Then we can use a mid-cut formula.
It is not after 400. When it becomes when it crosses 400, the whole thing will become 2.4 calculation.
2.4 calculation.
Up to 400, you 1. Add 1.6. If it is more than 400, from 100 to 500 or 600, each 100 you have to add 2.4. That will become almost double. That is a issue. So what will be the corrected sodium?
122. We get a VBG sodium is 113, GRB 644, corrected sodium is 122.
Okay.
Lactate was 4, potassium is 3.5, creatinine is 1.5. Then we taken a CBC point of care that showing total count is 12,000, CRP is 195. So according to the clinical history, with our own examination, GRB is 644 and VBG wise there is no acidosis. With hyponatremia and corrected sodium is 122.
Is it 122 is not okay or?
It is hyponatremia.
It is hyponatremia. Still it is hyponatremia.
So coming to a diagnosis of hyperglycemic hyperosmolar state, HHS. So we send the routine.
What is the osmolality calculated?
Calculated osmolality is 310. 310.
What is a normal?
Normal is 270 to 300. We will call HHS when more than 320 according to the criteria. Serum osmolality is 310 is done.
This so slightly
elevated.
Slightly elevated, but not up to the
meeting the criteria.
So what may be the reason for not achieving that criteria?
Patient in dehydration, not full. It's taken.
See, if you take HHS alone, then your criteria will be fulfilled only if the osmolality is more than 320. But here it is 310. But still you want to make a diagnosis of HHS. So there is some problem other than HHS in this patient. What is that problem? What is the problem? What is the problem which is preventing you to make a diagnosis of HHS according to the diagnostic criteria? Still, because of your clinical experience, you believe it is HHS. What may be the additional problem this patient is having? Normally, HHS, what will happen to sodium?
Sodium will
sodium will be normal or higher. Here, patient is having HHS. Patient has gone to HHS according to your clinical experience. But lab-wise, you are not seeing that because the patient is having additional problem. He is having some hyponatremia also there. That is another problem. So he is already having HHS, but you are not able to make a diagnosis because he is already having another issue, that is hyponatremia. Okay. So normally HHS means patient is not taking water alone. here you have what is the age of the patient?
64.
64. Patient might be she might have lost the insulin intake. She might have lost lots of volume through the urine. She might not have taken water, and on top of that, she might not have taken salt also. So everything contributes, and it can slightly alter your diagnosis, but still you consider it is HHS only.
So coming to summary history, but 64-year-old female patient, known case of diabetic, recent CVA and hypertensive. Patient came to ER with complaint of general tiredness since 2 days, and patient noticed the patient had decreased response and patient became progressively weak since 2 days. Patient also complained of decreased food intake and also complained of multiple episodes of vomiting and abdominal pain associated with dysuria. There is no history of
Abdominal pain indicates what? Do you suspect something else or only this one?
abdominal pain with dysuria suspected UTI.
UTI. What else? One is UTI, very
UTI.
clear cut, straightforward. Huh? Decay. So if decay it is there, you can get. But here you are telling there is no decay. But
UTI,
even without
pylori.
decay, also you can get abdominal pain. That is because of the dehydration, reduced supply to your intestine, all these things. Okay. What else?
Obstructive uropathy, pyelonephritis, mesenteric ischemia,
Pancreatitis. So that will be the third one. Okay. All depends on your water status. When you reduce blood volume, the ischemia will occur to your intestine, ischemia will occur to the kidneys, ischemia will occur to your pancreas. So everything is connected.
No history of altered sensorium, seizure, fever, constipation, negative history.
But you told GCS is low.
GCS is E3, V5, M6.
How much it will go? 11, 14,
Drowsy.
14, slightly drowsy. 14.
14. So we send the routine workup. Routine workup serum osmolality is 310. Total count is 12,000, CRP 195, HB 10, platelet is 2 lakh, hematocrit is 30. Creatinine is 1.
Hematocrit is how much?
30.
Normal. Or below normal.
Below normal. Normal. Lower range of the normal. Creatinine is 1.5.
What is the HP percent? Hemoglobin.
Hemoglobin is 10.
10.
Creatinine is 1.5. Urea is 66.
So what is suspect in this case? You expect high hematocrit, but this patient is having low hematocrit. How do you justify your answer?
Some fluids.
You need to explain, no? Should know. Should know at least how to bat in exams. Hematocrit value increases when you have severe dehydration. You know that already dehydration is there. But still the hematocrit value has not increased. Your hemoglobin is only 10. What is the reason? So it's a chronic anemia. So patient might have already had got some increased volume expansion in the blood vessels. But now because of DK or HHS, he might have lost some volume. But even then it's a chronic anemia. It's not an acute problem. It's a chronic anemia. This hematocrit, otherwise suppose you take the blood, it may be very low. Okay, now it has increased from the lower range, it has increased slightly. Okay, but we have not seen the previous values. That is a problem.
Then urine routine showing pus cells of 10 to 15 pus cells. Proccal is more than 100. And
so you suspect UTI?
UTI, and we done a
female patient 10 to 15 clinically, it's okay. Female patient 10 to 15 pus cells, is it normal or abnormal?
More than
elderly individual?
More than 5.
What is your opinion? So it can be urinary tract infection. I am not questioning that. But without a differential diagnosis, you cannot learn all these things. An elderly individual coming, you are examining the urine. It shows 10 to 15 pus cells. Can you make a diagnosis of UTI? What is the common cause for pus cells in urine in an elderly individual?
Taking sample, not midstream sample.
Midstream sample is required only for a urine culture. Viral UTI. I expect some other answer. Estrogen deficiency, elderly female patient, 65-year-old, estrogen deficiency, shedding of lot of epithelial cells, that will be mistaken as pus cells. Since this patient is having some abdominal pain, symptoms of UTI, you can make a diagnosis. Otherwise, normally if you take the urine of many patients, many elderly individuals, you can see these pus cells. They are actually epithelial cells. Okay, so you have to be very careful when you make a diagnosis of UTI. But once you get a proper history, lower abdominal pain, pus cells, culture positive, then it's correct.
Then initially we start with fluid treatment, resuscitation with.
So how do you know that patient is having dehydration?
Clinically, we can get hypertension, tachycardia.
Is there a hypertension here?
Hypertension, heart rate is 90.
What is the BP?
BP is 140/70.
So there is no hypertension.
No hypertension.
There is no tachycardia.
Heart rate is 90.
Sodium is, what is the sodium?
122.
120. There is no hypernatremia.
Hypernatremia.
Hematocrit is low. There is no high hematocrit. How do you
Then
know?
we check for CRT, capillary
I
fill
am
time.
not happy.
IVC.
CRT, all these things are correct. That is all MBBS level answers.
Check for IVC.
That you have to tell. You have to tell and you have to prove that there is intravascular collapse or water loss.
Then we can.
Is it
IVC is collapsing.
So you suspect water loss from the body. Okay.
Then we can check for monitor the input-output charting.
That is second day onwards. You can monitor that. Suppose the patient is having renal failure, that will not be possible. Okay. Then
when we start on fluid treatment with in HHS, we will 10 to 12 liter fluid will be lost in the body. So we will give it fluid of 15 to 20 ml per kg for initial 1 to 4 hours. Then after fluid correction, resuscitation, we will start on insulin infusion.
so what is done for this patient? You tell
Initially, we started on fluid resuscitation.
that. What fluid?
Normal saline, 0.9% normal saline.
What will you monitor when you are giving normal saline? In this patient, what all things you will monitor?
In fluid correction, we will check for sodium and serum osmolality correction and hyperchloremic.
Hyperchloremic acidosis will not be a problem in this patient because whenever you give normal saline, you get hyperchloremic acidosis. That is not a clinically important condition.
When decreasing of glucose, normally it takes 50 to 70 milliliter per hour. So rapid correction of hyperglycemia, rapid correction of the osmolality.
So how much fluid you had given in the first hours?
First hours we can start with 15 to 20 ml per kg.
So how much is around 20 ml?
Approximately 1.5 to 2 liter fluid.
So what happened to sodium? What happened to sugar?
Sodium becomes 122. It becomes not normal. It's like 124, 126. It becomes normal. Then osmolality also changing from 310 to 304, and sugars was also decreasing from 50 to 60 per hour. It is decreasing.
Okay.
So potassium was 3.5. We can start with insulin infusion plus potassium correction after fluid resuscitation. So we started with insulin infusion and along with potassium correction.
How much potassium is required for this patient?
3.5. It is normal range.
Okay.
So we can supplement 20 milliequivalent.
Okay.
Then we move on with further investigation for what's the reason for HHS. Clinically UTI is there. So we done a USG. USG was normal. Then inflammatory markers are raising.
What all things you look in USG abdomen and UTI?
Any cystitis,
free floating echoes.
internal echoes, synaptic uropathy, any pyelonephritis.
So this is a female patient. Female patient. What
Calculi causing UTI.
Calculi. Okay. Then
Any pyelonephritis. Structure abnormalities.
Okay. Strictures. Malignancies. Okay.
Then USG was normal. So we, because of the increasing inflammatory markers, they done a CT-KIB. CT-KIB showing bilateral.
What is procalcitonin?
100, more than 100.
100. Okay.
Bilateral pyelonephritis. So hyponatremia is one thing because of the UTI also. Patient is causing hyponatremia.
How it causes hyponatremia?
Loss of sodium through urine.
Okay. Will you start 3% saline in this patient?
Serum osmolality was 310 and so sodium is 122.
I'm asking very straight.
Need
Will you
for
start?
NV correction by eye fluid, so no need for start.
When will you start 3% saline in patient? If this patient is having 122, When will you start 3% saline in this patient?
The patient's sodium is less than 120 and patient had history of altered sensorium.
Okay, that is very important. If the patient is having history of altered sensorium, even at this level, then you have to try 3% saline. Otherwise, what you are doing
Fluid
is correct.
correction.
You are giving normal saline that contains some sodium. Most of the time, it will get corrected. If the patient is having altered behavior, severe weakness, unable to talk, then you will have to correct seizures. Then you have to do it. Okay. So insulin, how did you start insulin?
Insulin infusion we can start by 0.1 units per kg per hour we can start. When our aim goal is to
We can start means IM, IV,
IV
infusion.
infusion we are trying to
What
start.
is the difference between IV bolus and infusion?
IV bolus is rapid decrease in glucose, but we cannot control the bolus dose. If IV infusion, if we stop the infusion, we can control the decrease the sugar control.
What is your opinion about bolus and infusion? First dose bolus and first dose infusion.
According to recent study, bolus is not indicated in DK and HHS according to recent studies because bolus.
What is your opinion?
Can we try for better control? We are starting infusion in this case.
Both can be given, but there is no difference in IV or IV bolus or infusion. There is no advantage of our infusion our infusion for IV bolus. Okay, but if you have very high sugar, if you want to correct it fast, like provided that your rest of the things are normal, you can give IV bolus. Otherwise, there is no difference. Okay. Suppose you want to give it as a IV bolus 10 units every or 5 units every hourly. Is it okay? You don't have an infusion pump. What do you do? See, every hospital will not have infusion pumps like this. You are working in a peripheral center. You have insulin diluted and you have IV infusions. So can you give every hourly 5 units?
Bolus, IV bolus.
Can you give? Yes, it has got a equal efficiency like an infusion, but there is no added advantage of IV bolus over infusion. That's all. So if you have an infusion pump, always infusion pumps are better because you have a better control. But suppose you don't have an infusion pump, you'll have to give every hourly bolus. Okay, that is also possible.
Insulin infusion dose we can start by 0.1 units per kg per hour we can start. Our goal is to decrease the sugars by maximum 50 to 70 milligram per hourly. If it is not attaining, then we can increase the unit by 0.14 to 1.5.
If it reduces rapidly, what will happen?
If it is reduced rapidly, we can go cerebral edema.
In adults? What is the difference between adults and children? You reduce rapidly more than 75. Will it cause cerebral edema in adults? Will it cause it in adults or not? It can be. What is the difference between child and adult? Child, it is more like this, what you told. Cerebral edema is common in children than adult.
Elderly.
In adult, we are more concerned about hypoglycemia. Still, it can produce brain edema, but children, we have to be very careful. That produces clinically significant brain edema. Adults, it may not be clinically significant, but still it can produce cerebral edema. But here we are more concerned about hypoglycemic episode. Okay, patient may go to hypoglycemia, but even then what you told is correct. It can produce cerebral edema, but clinically may not be very important, unlike children. Children, we have to be very careful. So there are small differences between adult and child. Okay, but ultimately we have to treat adult also, like elderly individual has to be treated like child because their brain is also already shrunken.
Then it is started like if it is decreasing the glucose by more than 70, we can decrease the insulin infusion by 0.05 units per kg per hour.
Okay.
Then potassium correction is like if potassium is less than 3.3, initially we will correct the potassium and magnesium. First magnesium, then potassium. Then it start insulin infusion. If the potassium between 3.3 to 5, we can start insulin infusion.
What is the magnesium in this?
1.1.
What are the importance of magnesium in diabetic patients and diabetic ketoacidosis?
To act insulin, first of all, we correct the magnesium.
Magnesium is required for
Potassium.
insulin uptake to the cells. Potassium also it is important. Potassium correction, magnesium correction is the most important factor to be done first.
Then potassium is between 3.3
So how
to
much magnesium you have to give in this patient?
1.1. We can give 1 gram magnesium, 100 NS over 1.
How you know that the 1 gram is deficient? What is the correlation between your serum magnesium to body magnesium? How much percentage is there in the intravascular? Huh? So it only reflects 1% of your body magnesium. So it only tells you that it is deficient. We cannot assess how much is deficient. So we'll have to, sometimes we'll have to give more, 1 or 2 grams. We don't know. So we have to give and correct and see whether it is getting corrected or not. It is very difficult to only tell by seeing the 1.1 value in your serum and tell this much is deficient. That is not possible. Okay.
Then if potassium is between 3.3 to 5, we can correct we can give supplement potassium and start insulin infusion. If it's potassium more than 5, we can start with insulin infusion. No need for potassium correction. We will monitor the potassium. Then fluid treatment and antibiotic in this patient.
Culture?
Urine culture came to E. coli. It was pan sensitive.
What is a colony count?
1 lakh count.
Is that colony count is important? Yes or no? What is the colony count? What should be the colony count? More than 1 lakh or 10 to the power of 5. That is there? Okay. So what antibiotic is started?
Initially started on ceftriaxone, but patient is not clinically improving. Started on injection meropenem.
Meropenem. Okay.
CTK, big sugar pyelonephritis. So patient was not responding to ceftriaxone. Started on meropenem.
Why patient is not responding? It's a clinically, culture shows positive for this one. Ceftriaxone sensitive. ESBL is positive.
Yes.
ESBL is positive or not?
I don't see.
What is the importance of ESBL? You have to check that. See, culture sensitive to ceftriaxone. ESBL is positive. What does it mean? Culture sensitive to E. coli, sensitive to ceftriaxone. ESBL is positive.
Can be resistant to
It will be resistant to ceftriaxone. So it may be shown as sensitive to ceftriaxone. ESBL positive means then patient will not improve with your ceftriaxone. That is the problem. So you have to read till last of that culture report. In that it will be written. So ESBL is positive, negative, whatever it is. Okay. What is the marker you check for improvement in patient? In
You can repeat the procalcitonin.
procalcitonin. What was the procalcitonin first?
Initially more than 100.
Afterwards,
Afterwards,
you have to monitor it. You have to monitor and prove or disprove that it is not working. Okay. Sometimes ceftriaxone only will work. We don't know. If the patient has clinically not improved, then better to change it. What happened to the patient finally?
now patient is clinically not discharged. The patient is clinically improving.
How much insulin is required now? How much you gave us infusion? How much is the requirement now? Current requirement?
Mixed at 30 by 70, 30 units.
How many units? 30 units? BD.
BD.
60 units. So sugars are controlled?
Sugars are controlled.
Controlled. Okay. So either the infection has subsided, that's why your requirement has come down, or that may be the requirement for the patient at all. So 2 things you have to do. Anything else?
And other than in recent studies, it because of hyperglycemia and hyperosmolality, it is a hypercoagulable state. We can start with low molecular heparin also. We can
Why
start.
it is hyperosmolar state?
Hyperglycemia and hypercoagulability is the chance of thrombosis formation.
Why it is hypercoagulable state?
Because of osmotic dehydration.
Dehydration is the most important cause. Blood will be very thick now. Okay, so these patients can present with stroke, myocardial infarction. So there is a possibility of patient can come with all these things. So heparin can be given, but any patient admitted to your ICU who is not moving, heparin or low molecular weight heparin has to be given. within 48 hours, suppose you anticipate that there will not be any movement after 48 hours, you have to start heparin. That has to be given. Okay, thank you.